Hi, my name is Haven Campbell, and this is for my respiratory 2480 class. And today we are going to be talking about obstructive shock. So, what is obstructive shock? Obstructive shock occurs when blood can't get to where it needs to go. Conditions that can cause a buildup of air or fluid in the chest cavity can also lead to this type of shock. Obstruction can occur at the level of the great vessels or at the heart itself, and obstructive shock and cardiogenic shock are very similar. So obstructive shock is just when the blood can't get either to the heart or from the heart. So what are some common causes of obstructive shock? So causes include any type of obstruction that stops blood flow to or from the heart, such as a pulmonary embolism, cardiac tamponade, or a tension pneumothorax. So what are some physical examination findings that you might see on a patient with obstructive shock? They will normally have a low blood pressure, they'll be tachycardic and tachypnic, they will have hypoxemia or hypoxia, they will be cyanotic, they'll have cold and pale, sometimes clammy skin. They'll have a decreased or depressed mental status, a decreased urine output, and one of the big ones is you'll see with cardiac tamponade is Beck's triad, which is the patient will exhibit hypotension, they will have jugular venous distension, and muffled heart sounds. As in cardiac tamponade, there is fluid that is surrounding the heart, so that sound will be muffled. So some imaging studies that you can do to help diagnose your patient. Usually they will do a chest x-ray. If a patient does have cardiac tamponade, you will be able to see it on a chest x-ray big time. A CT scan, an echocardiogram, an MRI, and a ventilation tube perfusion scan. Those are mostly for like a pneumo or a pulmonary embolism. So some laboratory studies, what will you also pull from your patient? Normally you'll get a CBC, electrolytes, a renal profile, a coagulation panel, a D-dimer, and HIV testing. I didn't know this, but about 25% of all the pericardial infusions are to be associated with an HIV infection. So if a patient is experiencing cardiac tamponade, you might want to do an HIV test to see if they are possibly HIV positive. So some hemodynamic values. Because obstructive shock impedes forward flow, cardiac output is greatly diminished, and the clinical signs and symptoms can resemble those of hypovolemic and cardiogenic shock, depending on the specific cause. They will also show decreased cardiac output, an increased systemic vascular resistance, and an increased pulmonary capillary wedge pressure. So what are some invasive procedures for obstructive shock? You can do a pericardiocentesis. For cardiac tamponade, that's when they drain the fluid from surrounding the heart. A percutaneous balloon pericardiotomy for a cardiac tamponade. They'll do an embolectomy and a percutaneous thrombolysis for a pulmonary embolism, and possible needle decompression in a chest tube for a tension pneumothorax. So some pharmacologic options. Medication is limited for obstructive shock as kind of our three main causes for obstructive shock. There's not a lot of medications for them, but there are some, like an anticoagulant you normally want to give to someone with a PE. Diuretics for cardiac tamponade to help drain the rest of that fluid off. And beta-1 receptors, these are stimulating agents that increase stroke volume and cardiac output. So you would normally give this to someone who is experienced cardiac tamponade to help the contractility of the heart. So some ABG anomalies. In an acute pulmonary embolism, patients free from circulatory failure usually present a blood gas pattern consistent with respiratory alkalosis. And a tension pneumo will represent as a respiratory acidosis. So mechanical ventilation. Supplemental oxygen should be an immediate response to combat hypoxemia. So that's something that you would always want to do. Mechanical ventilation can be put into place if needed to help rid that CO2. And an excess and positive pressure ventilation should be avoided because it may decrease venous return and aggravate the signs and symptoms of cardiac tamponade. So it's already hard enough for the heart to pump blood out in a patient who is experiencing cardiac tamponade. So we don't want to increase the intrathoracic pressure to where the heart can't pump as it should. So just a little summary of obstructive shock. Obstructive shock is just when blood can't get to and from the heart. Some common causes are the tension pneumo, a pulmonary embolism, or cardiac tamponade. And Beck's triad is one of that big signs and symptoms that you want to see or you want to find in a patient who is experiencing cardiac tamponade. And there's not many pharmacologic options to treat the underlying issues. And you want to limit that amount of positive pressure ventilation if possible. We want to keep our patients stable, hemodynamically stable, and we want to keep that cardiac output in our normal range. And these are my references.